get us started for today, just to give our speaker as much time as possible. Thank you all for joining us. As you all know, this is our weekly seminar series for the Center for Healthcare Policy and Research here at UC Davis, and we have a mix of attendees, include students who are taking a one-unit seminar in public health sciences. We have some people who can take this for continuing medical education credit, and others who just like to join and participate in the scientific conversation across our community. So we rotate our topics on applied research examples, policy, community engagement, and health equity work. And I think you kind of touch on all of them. So we'll see where our amazing speaker will take us today on her remarks. But we're very fortunate today to have Dr. Shazia Siddique join us from the University of Pennsylvania. She's a gastroenterologist, and she also serves as the Associate Director of Scientific Research for the Center for Evidence-Based Practice at Penn. And she serves on the Clinical Guidelines Committee for the American Gastroenterological Association. You have a lot of amazing things in your career. I won't spend too much time on all of them, but including some previous work in the policy domain for the American Medical Student Association and with the Patient Safety Program at WHO. And so I think you have a lot to share with us, and I think especially in this time of change, we'll be really excited to hear about some of your programs today. Thank you so much for coming and speaking to us.
Yeah, thanks so much, Courtney, for having me. And I think you're right. This is a trying time for a lot of us who are doing the health policy research in general, but especially with the health equity lens, it's a lot of uncertainty. And so happy to share a little bit of my experiences doing this. A lot of it had been done, at a national level with the Agency for Healthcare Research and Quality, as well as through some national efforts. So I'm happy to chat about that. And since we do have a pretty small group, I'm very happy if anyone wants to interrupt me, ask questions, raise your hand. I'll try to monitor the chat, but if I miss something, like Courtney, feel free to speak up. I want to make this as useful for people as possible. And sometimes I think even just sharing stories about how, even not just the results of the work, but how the work gets done, and some of the challenges and barriers can also be, helpful and generalizable, relatable, probably to all of you who are really also, I think, leading the field and doing a lot of this work as well. So it's really an honor to be able to speak to a group like yourselves. So I'll be speaking about the impact of healthcare algorithms and guidelines on racial and ethnic disparities. I don't have any relevant conflicts of interest with ineligible companies, mostly federally funded, which is, it will be an evolving process, but as Courtney mentioned, I've done some work externally with other associations that have influenced my, intellectual feelings on these issues. So I'll start off with discussing background and terminology. Then we'll get into what do we know about the current impact of algorithms on racial and ethnic disparities? What have been some proposed mitigation strategies for those algorithms? We'll pivot to clinical practice guidelines, talk about how they are related to algorithms, but still distinct. We'll talk about that in the terminology section too. What approaches have been developed and what are some future directions? So I have just one slide on race and ethnicity in medicine, and you'll see when I discuss this that slide alone could probably be an hour-long conversation, but just to give a really brief background and then getting into defining some terms. So as we all know, there's been a problematic application of race and ethnicity in clinical care, and this has really stemmed from the historic false notion that race is a biologic construct. We know from the field of population genomics that there's more variation within a racial category than amongst them. And that's mainly because these are such broad, heterogeneous racial and ethnic categories with significant variability, not just in genetic ancestry, but also in social, cultural, environmental factors. And so ultimately, race, as we know it, is a complex classification that has been socially, politically, and legally constructed over centuries. And that's really evidenced by the fact that how racial categories are defined has evolved not only over time, but geographically in different countries and regions because of all of these different factors that can influence the classification. What's really important too is as we start to think about race and ethnicity in medicine is to recognize that the fastest growing group in the United States are individuals who self-identify as having mixed racial or ethnic background. And so as we have this historic root in race-based medicine where we say, give people care differently because of their race, it can be really problematic because and also just have limited applicability, as we think about our evolving population. So the underlying concept here is that both algorithms and guidelines may perpetuate the false notion that race is biologic and contribute to racial and ethnic disparities. And with this concept, we sought to study this a little bit more rigorously. So before we get started, one of the, and I teach this in some master's courses, and we always talk about it, how do you define algorithms and guidelines? And we all know that healthcare decisions are complex. And as clinicians, it's really helpful to have guidance on at the point of care and different steps in the care process on how to make decisions and different thresholds for that. And so we use these tools. Healthcare algorithms we define, and this was after discussing with national experts throughout the country through the Agency for Healthcare Research and Quality, as a mathematical formula or model that combines different input variables or factors to inform a calculation or an estimate. So something like disease risk or prognosis. The most famous one is estimated glomerular filtration rate, or eGFR, at least famous in the sense of this issue with race. We'll talk briefly about that later today. And then clinical practice guidelines, they may incorporate an algorithm or a model into the recommendation that they're making because that came up in their evidence base, but these are really distinct. So these are defined by the Institute of Medicine as statements that include recommendations to optimize patient care, need to be based off a systematic review of the evidence, and then you're weighing benefits and harms of alternative care options. So when you think about the USPSTF guidelines and many professional society guidelines, those were distinct from the pure mathematical models of algorithms. So healthcare algorithms, we have our traditional statistical models that many of us learned about in our epidemiology courses. There are the diagnostic models like eGFR to diagnose and classify kidney disease. There are the prognostic models that look more at risk prediction, and we use different thresholds, for example, to determine eligibility for screening or treatment. Ideally, all of these are hypothesis driven. So when we were taught, in our epi courses, that every single input that goes into the model should have a hypothesized relationship with the outcome. And this is why, it's also problematic, because at least for me, when I did this about a decade ago, I was also told that every single model needed to include sex, race, and age. And without really thinking about what's that hypothesis and why is race there, and is this biologic? As we start to think about machine learning.
Thank you so much.
Sorry, mute that.
No worries.
Make sure you mute. Thank you.
All good. As we start to think about machine learning and artificial intelligence, here is where things may be less hypothesis driven theoretically, because model fit may be prioritized over an understanding of biologic causal mechanisms. And this second bullet that says only as good as the data source and input variables, that's not really different from our traditional statistical models. Like if the data source and the variables are there, and we're not looking at variables that could be true proxies of race, you still can end up with issues. But this is actually what we see in a lot of our electronic health record algorithms and things that are really embedded into clinical care, to an extent that there's not even that much transparency. So I'm sure some of you have heard of eGFR, which was a diagnostic algorithm that originally included a race correction for Black individuals. And this essentially stemmed from flawed research that led to the conclusion that Black individuals have greater muscle mass and in turn greater creatinine than others, justifying the equation. Ultimately, this was resulting in disparities for Black individuals, including access to dialysis and kidney transplantation. And as many of you know, a couple of years ago, there was a national movement to remove race in eGFR that led to several modeling studies and ultimately was replaced by a cystatin C-based equation. There were two different versions that came out, but we've actually seen very impressively that this has been adopted widely over the course of the country. And we see, like at Penn, we don't even have race in the equation anymore. So it's really changed drastically. So as we start to think about the introduction of bias, Here in the top part of the algorithm development phase, there can be bias introduced in every single one of these steps, how we formulate a problem, we select our data, we train our data, but it also can happen as we're translating and disseminating it as well. And this is where clinical practice guidelines come in, because a guideline can codify a certain treatment threshold or decision point using an algorithm. And so guidelines, as I mentioned, are defined as systematically developed statements to make informed decisions. They include recommendations as well as this trade-off in benefits and harms. The IOM released standards in March of 2011 called Clinical Practice Guidelines We Trust, and really highlighted the importance of transparency, both in terms of methodology that's being utilized as well as funding. And conflict of interest is a really big one. And I can tell you, even in this day and age at the American Gastroenterological Association, where I've sat on the committee twice and have worked as a grade methodologist for them, this is our biggest issue. Half of our subspecialty clinicians have significant conflicts of interest. They're received money from industry, and it's really requires proactive divestment if we know we want to bring somebody onto a guideline, in addition to disclosure, of course. This same report calls for multidisciplinary guideline development group composition, and many people also argue that it should be diverse, and there are evolving requirements now that it should also include patient representation in a guideline panel. The evidence should be based off of a systematic review, a formal evidence synthesis, and not just a narrative review. There needs to be a method for rating strength of recommendations, articulating the recommendation in a clear and actionable way, and there needs to be transparent external review as well as timely updating. So once we do the systematic review, the next question is, we have this huge evidence base, how do we go to decision making? And this is where we use something called GRADE methodology, which stands for the grading of recommendations, assessment, development, and evaluation. And this is essentially a rigorous, transparent, and practical system to develop guidance. It allows us to rate both the quality of evidence and the strength of recommendations. So the old system basically said you have a randomized controlled trial that leads to high level evidence and a high level recommendation from the professional society, whereas observational studies lead to lower level recommendation. But we know that, especially for many of us who do epidemiology research, is that that's not necessarily always the case, and that the methods matter a lot. And as we critically appraise these studies, there can be some very poorly conducted RCTs and some very robust observational studies. And so what GRADE does is it recognizes the heterogeneity within study design and lumps that into this quality of evidence bucket. But it also recognizes that quality of evidence is one part of the puzzle here. We also need to evaluate that in the context of the balance of benefits, burdens, and harms, patients' values and preferences. And then, interestingly, as part of GRADE, and this is more than 2 decades ago, an original part of GRADE has been resource use, equity, and feasibility. So these are all outcomes that need to be considered when you are translating your evidence to a recommendation. And just also to add that there's something called the evidence to decision framework, which I like to mention because a lot of people who are in the equity space really talk about how guidelines don't always transparently publish this framework. And the reason why that matters is because this outcome of equity is specified in the framework, and guideline panels are supposed to clearly state how they think the recommendation may affect equity as part of a transparent process. And so sometimes we're not seeing that consistently published, but it's something that the USPSTF does consistently. And it's also something that's helpful to look at as to how they weigh these pros and cons of the recommendation. So GRADE adoption has been really widespread. You can see these are many societies that have adopted GRADE or modified versions of GRADE. But what I tell people is that we really need to have scrutiny to determine whether the document that you're looking at is just an expert consensus statement, which there's much more room for the introduction of bias, versus actually a rigorous GRADE methodology guideline. And so that, same thing, like not all algorithms or models are created equally, and not all guidelines or guidance documents are created equally. So now let's get into, what do we know about the impact of all of these decision aids for us on racial and ethnic disparities? So in 2020, there was an increasing awareness of many problematic clinical applications of race in algorithms. And this article, probably many of you have seen, was published in the New England Journal of Medicine. This was a commentary that really highlighted select algorithms, including EGFR and others that include race corrections. And in response to this, shortly after this, it was in September of 2020, 4 different Congress members and senators wrote a letter to the Agency for Healthcare Research and Quality. And this letter actually is, I think, is hilarious if you read it, because it's 4 pages long, and you can kind of see here at the bottom, they start talking about EGFR, but the other pages, they go into all these different algorithms, and they're really getting into the nitty gritty of how clinicians are practicing. And I will say, as a group of individuals who we had been previously quite autonomous and not really questioned, this was really, I think, unique that Congress members were saying, like, well, why are you guys using race in your algorithms, and what are you doing, and what's the justification, and what is the impact that this is having? So they really highlighted this concept of race-based clinical algorithms, and they said we need to better understand what's going on here and what is the impact on our populations. And so the agency responded with putting out a request for proposals to conduct a systematic review to understand what is the effect of algorithms and their mitigation strategies on racial and ethnic outcomes. And this was awarded to our team at Penn Medicine and ECRI, which is a research institute here in Pennsylvania. So this work was ultimately published last year externally in a journal. And what I was starting to tell Courtney at the beginning of this call is that the full report was on the AHRQ website, but now unfortunately has been taken down. So that's a little bit unfortunate, but we haven't been told we can't distribute it. So if you want to email me and you want to see the full thing, I do have it. And the main difference from what's in the actual publication is that we look at 4 additional contextual questions on, how do patients feel about it? What are the current guidance documents on it? So we actually really go into a lot of details. That report's over 100 pages long. So obviously did not fit into the word count of any publication. So what are some of the key decisions that we had to make when looking at our protocol? And I think this is helpful to really understand the results. So I just want to go through it briefly. First was that you saw the congressional letter really talked about race-based algorithms. And initially we thought we would focus on that. And actually we initially thought we'd focus on just race-based algorithms and outcomes that were worsened for disparities. But what we decided to do is actually look at all algorithms in clinical use, regardless of whether they included race as an input or not, and also look at any effect on racial and ethnic disparities. And I think this was actually something that, more than we could have anticipated, ended up being very useful, because we were able to show just have a more of an even conversation and more of an objective conversation as we were engaging with different stakeholders, health systems, the EHR systems, algorithm developers, and really say this is the spectrum of the impact of algorithms rather than just cherry picking a few negative ones. We also required that clinical outcomes had to be reported, and we grouped these outcomes into health outcomes. So that meant mortality, morbidity, quality of life, access outcomes, which included using, use of healthcare services and population health services, as well as cost, and then quality outcomes, which had to do more with appropriateness and timeliness of care, also included things like patient experience, satisfaction, readmission. But the reason I really highlight the clinical outcomes part is because there are a lot of studies that will show differential performance across racial and ethnic groups of a certain model and show how potential harms. But if they're not actually reporting clinical outcomes, and they're just giving us like model fit data, that was not included for our first key question, which is really looking at the impact of algorithms on disparities. And then, a little bit to my dismay, since I live in the guidelines world, the guidelines were excluded unless it was algorithm-based. So if it was an algorithm-based threshold in a guideline, we included that. But if it was a race-based guideline recommendation that did not stem from an algorithm, that was felt to be outside of the scope of this work. So what did we learn? We acknowledged that the potential effect of an algorithm really spanned across the spectrum. They could reduce racial and ethnic disparities, perpetuate or exacerbate it, or fall somewhere in the middle. we found a series of 5 studies that reported reducing disparities. Some of these algorithms include race, like the kidney allocation system, and others don't, like the lung allocation score. Both of these 2 models are used to allocate organ transplants. There were also 2 other algorithms that were both prostate cancer screening algorithms, and both of them include race. And so as we were trying to come up with understanding what were the commonalities across these algorithms, because it wasn't very clear that some of them include race, some of them don't, what we noticed was that there was a common theme, that there was often an awareness of pre-existing disparities and an aim to tackle them. And so for prostate cancer screening, for example, initially the algorithm did not include race, but they found that they were doing excessive numbers of unnecessary biopsies in Black men, and then they included race, and then they were able to set different thresholds and actually reduce disparities. So while many people would argue that, race is still just a proxy for something else, and we need to figure out what that is, whether it's an environmental factor, maybe a genetic factor, that, sometimes when we don't have those data available, still, using race and accepting it as a coarse, heterogeneous variable may help to reduce disparities despite its limitations. There was one study that was a study of an algorithm called the heart pathway. This is an algorithm that's used to triage chest pain in the emergency department. I don't know if any of you use it at your institution. We don't use it here at Penn, but it's used widely, like a lot in North Carolina and the Duke systems. And what they concluded was that there was no measured effect on disparities as a result of the algorithm. But interestingly, clinicians were actually less likely to adhere to the pathway when the patient in front of them was a woman. There were also some differences by race, although they were not statistically significant. And so this really highlights that clinical application matters. Like the algorithm itself may be trying to standardize care in a way that, shouldn't affect disparities, but there can still be clinician behaviors that lead to differential adherence of a pathway that then impact real world outcomes for clinicians. So although it's not attributed to the algorithm, these disparities can still occur. And then finally, the vast majority of the studies that we found did fall into the category of perpetuating or exacerbating disparities. Some of them include race, like EGFR, and some of them don't, like many of the EHR algorithms. The one study that I like to share and highlight, it was a study that was done by Ziad Obermeyer in Science, where he shows really nicely an algorithm that was in the electronic health record. And what he talks about was that they had this data set and they were trying to give additional resources, so care management resources, to vulnerable populations. But the problem was they wanted to identify patients who had the greatest need for these resources, but there's no variable called greatest healthcare needs or something like that. So instead, what they used was a variable that showed costs for that patient over the past 3 months. And they used that as a proxy for healthcare need. But when he looked into the data, he found that for equally sick Black patients as white patients were just more likely to have higher costs. And so even though they were equally as sick, the algorithm was systematically routing resources toward one group and away from another group. And then he went in and showed how, by creating better proxies, like for healthcare need and using multiple different variables that don't have differential effects across racial and ethnic groups, that you can actually identify patients who are the sickest and may need it the most without exacerbating disparities. So this was the table that ended up in our publication, and not to talk through it in a lot of detail. It's also, very small, but just to kind of show the way that we characterized it. So all of them that had reduced disparities are here, color coded by green. And I like to show this table only just to show the variability in the types of outcomes that were reported in terms of health, access, and quality. And you can also see that we have this column here that does it include race or ethnicity data, what kind of study design was it, and then perpetuate or exacerbate, these were the outcomes that, came up here. And actually, I didn't go through all of them for the sake of time, but you can see that there were a bunch of them that had to do with how they were actually triaging patients in the emergency department and looking at severity of illness and then applying that to resource allocation. that was ending up exacerbating disparities. So I wish I could tell you that we did this review and it was very clear that every single time you did one thing that was always going to cause harm and everything else was okay. But unfortunately, it's a little bit more complex than that. We found that these biased algorithms do appear to be pervasive in healthcare, really recognizing that not all algorithms are bad. The vast majority of them are likely good. And they're honestly just not studied as much as to all the good they are doing and being reported on by racial and ethnic groups. But that race and ethnicity probably should be avoided in prediction models. And if you're going to use it, provide a justification. What do you think it's being used as a proxy for? Did you try to replace those variables at that time? And really recognizing that implementation and intentionality matter. One of the algorithms that came up as we were, presenting this to the NIH was this algorithm that was intended to calculate which patients were highest risk to no-show to a clinic visit. And when it was actually applied to a large health system, this was embedded in the electronic health record, they found that what they were doing was taking all these patients who are likely to no-show to their clinic visit, double booking them to make clinic just more efficient, but that was preferentially consistently double booking patients who are Black and who are Muslim. For some reason, those are the two variables that came up. And so, you can imagine from their perspective, they have barriers to attending their visit. Now they've attended, but now they're being rushed because they've been double booked and they have worse, trust in the healthcare system because now they're being rushed and, everything. So it's really kind of exacerbating in a real world clinical setting these issues. And when we talk to the algorithm developers about this, I'll just so distinctly remember this. We're like, this is like a bad algorithm. They were like, no, our algorithm is great. The issue is what you're doing with this algorithm. You are double booking people. If you were saying these are the patients who need the most help and we're sending them a Lyft or an Uber or social resources to get their appointment, like you would actually probably be helping the patients who need it the most, but instead, it's what you're doing. So it really kind of highlighted this issue of, implementation and intentionality matter. But that finally, the evidence base is limited, even though we had tens of thousands of hits when we ran our search strategy, but you saw that the evidence base was really small. And that was really had to do with the fact that, we're really not reporting on clinical outcomes and the effect of those algorithms on clinical outcomes. So really, I think what we found is truly just the tip of the iceberg. So the second key question that we looked at for the same report was, what is the effect of interventions to mitigate racial and ethnic bias in algorithms? We really looked at all of these steps, whether it's development, validation, dissemination, implementation. And here, the evidence base was much more strongly modeling studies. And here we did not require it to have the same type of clinical outcomes. Always, it could be more, modeled clinical outcomes and more theoretical simulation studies. We ended up finding 7 overarching categories of mitigation strategies. The most common approach, which was used in 24 out of 44 studies, was to remove race. Not surprisingly, this was the study that was predominantly used in studies for EGFR, but we also saw removing race in other studies, so kidney donor suitability, postpartum depression, amongst other algorithms. The next most common strategy was replacing a variable, usually race, with something else like social determinants of health. Sometimes there was adding in race. Prostate cancer was an example of that. Adding non-race variables, and then algorithmic recalibration, stratifying the population by racial and ethnic groups rather than risk adjusting it. And then there were a series of different statistical techniques that are not captured very well in this bullet number 7, but if you read the report, we kind of go through on what all of those were. So this was a really big evidence base, unlike the first one, and was also very heterogeneous. And so the report dives into it in detail, and definitely, and the Annals publication does as well. So definitely recommend kind of going through that if you're interested in the real detailed implications. But just to show you one example of how complex this was just one strategy, removing race, and I'm just showing you one algorithm here, which was EGFR. This was our largest evidence base. So in some cases, you can see it increased access, and in other cases, it reduced it. And what we ended up concluding was that removing race from eGFR may increase the likelihood of diagnosis of chronic and severe kidney disease in Black patients, which could result in broader and earlier eligibility for kidney transplant. But conversely, it may reduce access to other types of treatment and affect medication dosing for a broad range of conditions and reduce enrollment of Black patients in clinical trials. And I just think this is important to talk about because there are always trade-offs and outcomes, and especially as we look at clinical guidelines and making decisions on various thresholds in a model and clinical care, just recognizing that these trade-offs are real. And even amongst the people, because we interviewed almost all of them who sat on that task force to remove race from eGFR, some of them worry that this mortality benefit may not be seen very much because many patients may just be sitting on the transplant wait list for a very long time, and that some of these trial eligibility and cancer therapy access issues may be felt first before we're able to over time see the changes in these outcomes. So just something to think about and recognize as we develop different strategies as well. So not surprisingly, I mean, most studies are reporting positive findings. So most of the mitigation strategies and those 7 that I showed you said, oh, we successfully reduced disparities. But the problem is that the evidence is based on modeling studies, and often that doesn't account for real world clinical application. And we've already seen how clinical application can affect outcomes as well. Many of these strategies improve algorithmic accuracy, but then required further inference and simulation to actually estimate the effect on disparities. Unfortunately, it seems very unlikely that we're going to find one solution for all algorithms. Then the context, population, and intentionality matter as well. This was a NIH workshop where Courtney and I met actually, and we were able to really start to think about an ethical framework for AI and biomedical and behavioral research. And that report is available. And I like to talk about this in the context of mitigation strategies, just to show that even though there may not be one size fits all for exactly how do you alter your algorithm to improve disparities, there are approaches that are more methodologically rigorous, that are consistent with ethical frameworks, and also allow for more transparency in model development that can be utilized. So moving on to clinical practice guidelines. As we think about the role of guidelines on racial and ethnic disparities, we had the same framework, that it can really span across this entire spectrum. And really recognizing that guideline recommendations can impact disparities regardless of whether they include an algorithm or whether they include race-specific decision-making. And similar to algorithms, there is so much focus on the race-based ones, understandably, because they do perpetuate the false notion, especially to clinicians who are like literally being told, treat a patient differently based on the color of their skin. Like, yes, that is problematic. But just recognizing that even if they don't do that, we can still have impacts on disparities, and really kind of thinking about all of our guidelines from an equity lens can be important. So the United States Preventive Services Task Force has actually really been at the forefront of developing methods to mitigate bias in their preventive services. And so this was initial paper that they put out in JAMA calling for a culture of inclusivity and diversity, re-examining their guideline processes, and reviewing equity implications of their existing recommendations. They actually since then, in just end of last year, published a health equity framework that goes through how to develop guidelines with a health equity lens. Unfortunately, unlike our algorithms report, that was never published externally. And so that has now been taken down from the website. So again, if you want a copy, email me. It's actually it's really good. But yeah, it's not publicly available anymore, unfortunately. So as a gastroenterologist, and I like to give this example, even though I know rarely do I have an audience of gastroenterologists, I decided to apply this to my clinical specialty. And I think this is just really to show that you really can do this in any specialty. So we did a systematic review to identify race-based recommendations. And I just finished telling you that it's not only about race-based, but yes, that is the lower hanging fruit. And many of us kind of start with at least doing that. So I did a systematic review of GI guidelines over the past 10 years across 4 different societies. Still don't know why we have 4 societies in one field, but when I find out, I'll let you know. We found 8 different recommendations in 4 topic areas. And so these are the big picture areas. So how do we screen for hepatocellular carcinoma, which is a type of liver cancer, and patients with a chronic infection of hepatitis B? How do we do surveillance for gastric intestinal metaplasia, which is a condition that is precancerous and lives in the stomach? And then screening for H. pylori infection, and then screening surveillance for Barrett's esophagus, which is another precancerous condition. So these were the 4 areas. And, not to, sometimes when I do have GI audiences, I do go into the details of these, but I know that some of the clinical nuances can be, very specific to that field. So what I wanted to show is just a very basic example and highlight the hepatitis B one, because actually really interesting. The guideline up until, so this was a guideline published in 2018, stated that you should screen Asian men who are over 40 years old and women who are over 50 years old with hepatitis B. You should be screening them for HCC, which is the liver cancer, hepatocellular carcinoma. And it also says all Black individuals of any age should be screened, which is really interesting because this is very race-based. And also, the actual wording in the guidance said something like all Black individuals / African patients or something like that. So it really was just truly by any skin color or whatever was there. For those of you who don't know, how do we screen for liver cancer? You have to have an ultrasound of your abdomen and a blood test called alpha-fetoprotein every 6 months. And this is a significant burden. We do colon cancer screening and I do colonoscopy. You're done once every 10 years, move on. This is every 6 months for the rest of your life that you're getting screened. So and there are lots of studies that show downstream psychological harm, burden, financial, et cetera, of needing to be screened. And of course we should be screening the people who are the highest risk, but just to tell people that because of their race and age alone, that's driving your risk factor. Now, why did this happen? Well, the rationale, and I think it stemmed from the desire to be inclusive, which was that in many Asian and African countries, hepatitis B is very prevalent. And because vaccination was not widely available, what was happening was that when a mom was pregnant, she would transmit the virus to her baby. So that's called vertical transmission. And then many babies were born with hepatitis B and never even knew. And then they would have chronically high levels of the virus in their blood called viremia, which then would predispose them to liver cancer. So it's really just having hepatitis B for a long time and having this virus untreated and in your system because vaccination is not widely prevalent. So that was the reason. And also a lot of the professional societies in Asia and in Africa were calling for universal screening for people, which is why I think the American guideline decided to adopt that, even though, risks change also depending on your context and your country of origin. So what we did was we went around the country and we asked people, so if you have a patient who immigrated from a country where hepatitis B is endemic, and you think they probably had it from birth, would you screen them the exact same way that you would screen somebody who is, born here in the US, maybe had ancestry from elsewhere, but you know how they got it. They got a needle stick exposure. And say the same exact person had the same exact needle stick exposure, but was white, would you screen them differently? And it was actually really interesting, the variety of answers we got. Some people said, well, yes, they have an inherently different risk of ending up with liver cancer. So I would screen them differently. Or I would screen them, these groups the same, but the, racial groups differently from others. Whereas other people said, no, this doesn't make sense biologically. Your risk of getting it is completely different because you don't have these chronically high levels of virus in your bloodstream since birth, basically. But we really kind of show the cognitive dissonance here about how this is not just driven by race. And when we published this too, we said race is clearly being utilized as a proxy for something, whether it's just chronically high levels of the virus or, the country of origin and, no vaccination at birth. And so actually, surprisingly, as a result of that paper that we published a year and a half later, well, less than a year later, they convened a guideline panel. And then a year and a half later, they published this guideline that just came out last summer that removed race from their criteria and added instead origin from a hepatitis B endemic country, which they defined as prevalence greater than 2%. Interestingly, they actually included a new calculator, so an algorithm. It's called the PHB score. Hasn't been very widely validated in diverse populations, so there's some chance that this will be an ongoing iteration. But just to show the map of the world, where you can really look at hepatitis B prevalence and see that saying all individuals who are Asian or all individuals who are Black should have the exact same treatment regardless of country of origin really didn't make sense. And also then thinking about like now all those individuals are in the US or Canada or wherever and are vaccinated at birth, it's very, these are very heterogeneous groups. So the issue now is operationalizing the guideline. And I like to talk about this because as we move away from using race, we recognize that there are new challenges in utilizing the proxy variables because now we need to collect data on whatever that variable is. So in this case, it's country of origin. And we actually did a study here at Penn. It's not published yet, so I didn't cite it or put it in here, but it's under review. And we found that country of origin data in our actual discrete field in our electronic health record was actually missing in 97% of patients. But when we use natural language processing, we actually found that most clinicians are asking this question because it was so relevant to the clinical history, and we could find it in more than 80% of charts if you just use NLP. But even operationalizing that, mapping it to which countries actually have a high prevalence of hepatitis B, recognizing that that's evolving. Now some countries are starting to do universal vaccination at birth, like things are changing. So even for a clinician to have to keep track on a year-to-year basis, which of these countries have a high hepatitis B prevalence can be challenging. And then, like I mentioned, there's a need to validate the PHB score in more diverse cohorts. So ultimately, what's been recommended for guideline panels is to try to avoid the use of race and ethnicity in clinical recommendations and use more precise variables when feasible, and be transparent about why you're using race and ethnicity and what are the implications on health equity. And where applicable, call for future research to understand the role of social determinants of health and other proxy variables on disease incidence, outcomes, and response to treatment. So how do we approach mitigating bias in the clinical guideline development process? Like I mentioned, the USPSTF framework is now, unfortunately taken down, but we've had a very similar approach with the American Gastroenterological Association. So I'm just going to share that. And this is, thinking about guideline development from the beginning. How do we select a guideline topic, to who's sitting on the guideline panel, to what does our protocol look like, defining our PCOTs, so patients, interventions, comparators, outcomes, timing, and settings. So just like the scope of our review, how do we assess study quality, and actually the recommendation formulation. So like I mentioned, grade methodology is considered to be the gold standard for guideline development, and we do utilize that in all of our guidelines. We have an associated systematic review with quality assessment and making sure that we're following Institute of Medicine standards. I don't know how many of you have been involved with a guideline panel or a guidelines committee, but every single time I do it, I always learn something new. And one of the things that's interesting is how we select guideline topics. So usually what happens is we put a call out to the professional society members to ask them what guideline topics and recommendations are needed. And then we have what's called a vetting form. So internally, there are a series of questions where we look at, well, what does a preliminary search look like? Are there even enough evidence to answer the questions that people are interested in answering? Are there other professional societies that have already answered this? And would it be redundant effort? And so one of the things now we've done is added a question to our form that says, are there known health disparities in this area? Could there be a potential contribution of this guideline to promoting health equity? And again, this is like one of many factors that contribute to better understanding the landscape of that guideline topic, not the sole factor, of course, in selecting it. Diversity of guideline panel, pretty self-explanatory there. When we think about our protocol and the scope of the review, really thinking a priori about including outcomes like equity, resource utilization, and cost are really important, because oftentimes, and you see this even in the USPSTF, they'll have their evidence decision framework, and they'll say, oh, there was an evidence gap for equity. We don't know the effect of colon cancer screening strategies on equity. But those studies exist, but they just didn't search on it, so they didn't find it, so they can't report on it. So really making sure that you're searching ahead of time to have those data to inform your decision. Next, there is an entire field of literature on how we assess study quality. We use these critical appraisal tools. But what we realized as we were going through the algorithms report was that assessing racial and ethnic equity related bias was really not embedded into the existing tools. So we built a critical appraisal tool extension, and we actually worked with the senior author here, Jennifer Lynn, is the senior grade methodologist for the USPSTF. So we worked with their team, and this is our team at Penn and Equity, to develop, and we used a modified eDelphi process to develop a new critical appraisal tool that considers some of these aspects, like, is there differential performance of the model across racial and ethnic groups? You know, how are they defining race and ethnicity? How are that data derived, et cetera? And then finally, you know, as we mentioned, when you're actually formulating your recommendation, you want to think about guideline content, how these results may vary, having a transparent framework for considering equity, and then explicit discussion of research gaps. And we really don't know, there's certain insufficient representation of Indigenous populations, for example. In terms of future directions, there is really a need to have many different aspects, and we've published this in a commentary in Health Affairs, of really engaging all involved stakeholders, having representative data sets, transparency, accountability, and really thinking about using more precise variables as well. The Council of Medical Specialty Societies has really taken a lead in this area, and this is a new alliance called the Encoding Equity Alliance that is actually funded by the Doris Duke Foundation, that's committed to really reassessing the use of race in both algorithms and guidelines. And this actually just kicked off this year, so in January of 2025. There are several different task forces, including AI, ML, clinical professional societies that are doing this work. So what are some takeaways? I often tell people, it's really important to not have blind trust in algorithms and guidelines, although we use them all the time as clinicians, to really do your own critical appraisal. Recognize that not all algorithms and guidelines are created equally. Mitigation solutions may take time to develop and test because there isn't really a one-size-fits-all. Really have to see how it works in your population, in your context. And just to highlight this, now it's not new anymore, but the NASEM report that came out a couple months ago, we had given testimony for this as well with this report, algorithms report, that now they talk about rethinking race and ethnicity in biomedical research. And ultimately what they really highlight is a lot of the concepts that we talked about here, which is that race and ethnicity is often being utilized as proxies for variables such as genetic ancestry or social factors, and really trying to replace them when feasible. And the prologue is really powerful, actually. The chair of the task force himself, I think he discusses how his mother is Japanese, his father is Black, and how his own racial identity evolved over time. And that really speaks to that notion that I talked about on the first slide, which is that there's truly a limited applicability to this growing number of groups with mixed racial and ethnic backgrounds, and that we're really being coarse by continuing to utilize these variables in clinical decision making, and failing to recognize harms of doing so. So I'd just like to acknowledge the people who worked on the report with me. These were our analysts who co-led the day-to-day work, but we had a very large team from Penn and Equity. I'm happy to take any questions from the group.
Such a great talk. Covered so much. I really appreciate it. I have a few questions, but I want to pause and open it up and see if anybody has a question for Dr. Siddique. Patrick, you have a question?
Yeah. Hi, can you hear me?
Yes.
Yeah. Hi, this is Patrick Romano, and really enjoyed your paper. And we sort of have a similar background in some ways, in that I was legislative director of AMSA years ago, and also national president for a year. But that was a little bit before your time. In any case, we're also struggling. I manage a website for ARC called Patient Safety Network, and we're also struggling with issues of content been taken down. But my question is, I didn't see it in your paper, but probably the most commonly used algorithm in primary care is the AHA-ACC algorithm, the so-called pooled cohort equation for estimating 10-year cardiovascular risk. And of course, that feeds into the US PSTF guidelines with respect to treatment of with statins for patients who may be at risk for a cardiovascular event. This, of course, is patients don't have a known history of atherosclerotic cardiovascular disease. So it's primary prevention, and it targets thresholds of either 7.5% or 10%. And race has been part of the pooled cohort equation. In the newer prevent equation, it's been taken out and perhaps substituted with better markers like the hemoglobin A1C. But I'm curious if that was part of your analysis, and if you could reflect on the journey that we've gone through with those cardiovascular risk equations.
Yeah, no, absolutely. Well, first of all, I appreciate your question and great to meet you. Yeah, so actually Shazia Khan, who I think was the first author of that paper that took out race from the pooled cohort equations, I actually spoke alongside of her at the Encoding Equity Summit last year, which is the same thing that Doris Duke funds. It's happening again in June, so highly recommend if anyone can attend. It's in Washington, D.C. But yeah, that was a really impressive effort. It did not come up in I'll say the two biggest criticisms of our report was that when we looked at the impact of algorithms on disparities, that first key question, because we were so strict with the types of outcomes that needed to be reported, like if you just gave us like a proximal outcome, it didn't get included. And so the two big ones that were not included were this one that you're mentioning, the AHA-ACC algorithm, and the other one that didn't come up was VBAC, vaginal birth after cesarean section, which is another one that has received widespread discussion. For those of you who are not familiar, that essentially was an algorithm that included Black race and said if you were a woman who needed to undergo vaginal birth after cesarean section, Black race was a negative risk factor to allow you to do so. When we looked at mitigation strategies, though, both of those algorithms came up. And what we write in the report is that clearly there is clinical awareness and acknowledgement that even though we're not seeing these end clinical outcomes in terms of mortality, we clearly can see these proximal outcomes on cardiovascular disease, and that is still sufficient enough to know that there is harm. And especially for something in cardiovascular disease that's very significant, you can argue that vaginal birth after cesarean section has different types of implications, but of course there is a very huge disparity in terms of maternal morbidity amongst Black populations that had gotten a lot of attention as well. But when if you look at the mitigation strategies section, those come up. PFTs also came up there, whereas not in the first question because of some of these limitations and how we scoped that. What we were really trying to do there was to avoid the use of algorithms that were just essentially people's master's theses and said, well, this could have an impact, but not really looking at all these end outcomes in real world data. So that was why that evidence base was pretty small. But yeah, in speaking with Dr. Khan, the cardiologist at Northwestern who led that, it sounds like they essentially combined numerous, dozens and dozens of data sets in order to get a very diverse population. I think it's called Prevent, their new cohort, to really take out race. And even that, I know she's gotten criticized because of the way that certain people are reclassified in terms of severity of disease, but at least it is a race-free score. And so,
and in fact,
yes.
Sorry. I think even just this week, I saw something come out in Lancet saying that, the race coefficient isn't big enough in the pooled cohort equations, at least for patients with HIV, and that it potentially discriminates against patients with African-American patients based on underestimating their risk. So this is, so it's tricky business, but thank you.
Yeah, of course. And this is, if you are, for individuals on this call that are involved with the professional society, there is actually a request for proposals out right now to reassess the use of race in guidelines and algorithms, and they're funding it from Doris Duke, which I think is a very unique opportunity because these days the funding environment is so scant and uncertain with health equity. So I will definitely be applying for that. And apparently I'm asking for more competition, but I still think, we need to advance the field forward and advance the science. So if anyone's interested, I'm, happy to distribute that as well.
Thank you so much. If no one else has any other question, I'm gonna ask my final question for you. I just love how much nuance. I mean, I'm not as detailed in this topic as you by any means, but I'm trained in EPI and health services research. So a lot of what you say really resonates with me. And I'm curious that level of nuance. I wanted to know if you could leave us with, do you really think there'll be a future where we'll have this level of nuance when we're thinking about algorithms? And do you feel hopeful about some of the, there's a lot of methods we can use, there's a lot of approaches, but that intentionality that you're talking about seems like such an important theme. And I was curious if you could, what's your pulse on sort of where we're headed? And do you feel like people are really cluing into how nuanced this really has to be in the future?
Thank you so much for that question. And I think sometimes it can feel really insurmountable with all of these different, checks and balances that need to be there to make sure that we're not causing harm, right? I would say that what's been really promising to me is that even though there can be just inconsistencies in algorithm development, that there's been a lot more focus on algorithm deployment, monitoring disparities that occur, revising algorithms when needed, and redeploying. And at least that to me brings some hope. We've seen, individuals at the Mayo Clinic and, the Center for Healthcare AI, really kind of publish guidance on how to do that and how to have this iterative process to algorithm development. So I think there are models out there, especially those that are more at a population health level. The ones that are more black box embedded into our health record systems, we don't really know what's in these algorithms in order to alter them. I think the transparency is really the biggest issue. So that's something that I think, and that needs to happen first before we can really, move beyond that. But for the ones where we have a little more control over what we're deploying in our health systems, I think there is at least a culture shift in recognizing that we do need to be monitoring impact.
I think that's a great place to end. It's sort of at the beginning, what are you really trying to do? What are the variables that you're choosing? And at the end, how are you implementing, and what are you thinking about in the deployment and the implementation phase? If you're thinking only about the model itself, you're missing sort of a lot of the full spectrum. So really love how you think about this. I'm so glad you're a national leader in pushing us forward. And I really appreciate you taking time to join us today. I know you put your email in your slides. I know you will answer emails if people have follow-up questions for you. But thank you again for making time with us. And I hope to see you in real life another time soon.
Yeah, that sounds great. Thanks so much for the opportunity to join you guys today, and happy to be in touch with anyone for anything. So
appreciate that. Thanks so much. Have a great day.